Thank you. Thank you. Okay, thank you so much. Welcome, welcome. Let's get these obnoxious photos off the screen. We were told to keep them on the whole time. Thank you all so much for being here. We are really, really delighted in the opportunity to be here with you guys. Let me know if at any point if you can't hear us, okay? So Jasmine and I get to the privilege and honor to work at Lawndale. I'll say a little bit more about that, but we specifically work in the areas of our residency program. So we started a residency program about 5 years ago, and so we get the privilege to talk with you all about how to not only live out faith in our medical practice and how to live out being mindful of having health equity and living in the community, but we get to teach it, which is a unique privilege. Let's see. So this is our community. This is a map of the neighborhoods of Chicago. There's a lot of neighborhoods all within the city of Chicago. This is where we're located. So we're in North Lawndale and La Villita. Lawndale is kind of right in the border of those two areas, Ogden Avenue right there. The top photo is a classic photo of North Lawndale. Lawndale is known for its notable largest concentration of these beautiful gray stone buildings all throughout Chicago. In its past, like in the 60s, 50s, it was known for being a really bustling community. I don't know if you guys remember, so there's a lot of young faces in here, but for the ones who are my age and older, if you remember Sears or Roebuck's catalog, the headquarters were in North Lawndale. We actually, as a residency program, just went on a tour recently, and so we went all throughout the historic areas of North Lawndale. This also historically was an area where MLK Jr. came during the Civil Rights Movement in 1966 and combated much of the redlining zone laws that were there. And so his headquarters were there, or he lived in that time in some of the apartments just miles away from their clinic to really make a mark in recognizing, hey, the things that are happening, the redline zonings that are happening in Chicago, this is not right, this is not okay. And so part of his movement in the Civil Rights Movement was in North Lawndale. The bottom photo is La Villita. So this is the classic arch that was given to us, what did he say in the tour? Was it given to us from, was it Spain? Mexico, yeah. Given to us from the president of Mexico back, I don't remember how many years ago, but maybe 40 years ago or so. This area is known as the Mexico of the Midwest. And so this is 26th Street, which is a bustling area, the second largest economic area in Chicagoland, right? Most people think of Michigan Avenue as being the area that is like the most money spent. This is the second largest in the city of Chicago. It is also full of authentic, delicious Mexican food, a bilingual atmosphere, and just a really strong sense of deep community. If you can see, this is Farragut Career Academy. So this is one of the parades that happens regularly in Chicago, and Farragut Academy is a high school that's located in La Villita, where actually one of our clinic sites is located too. So as you can see, Chicago is vibrant, it's beautiful. Our neighborhoods we love. Many of our providers that work at Lawndale and serve at Lawndale also get to work there, get to live in the area. What you don't see, wrong way. What you don't see are the significant inequities in those photos. So this is a map of, I'm so sorry about the mic. This is a map of the life expectancy in Chicago. Less than 65 is the really dark area, so that North Lawndale, and a little bit lighter blue is La Villita, 70 to 80, 74 years old. In 2023, the opioid-related overdose reports, again, those are two areas of North Lawndale and La Villita. So it's an area that also, what I alluded to when MLK came to our area, many Black people in the area were not allowed to live in certain regions. It was what was called the redlining zones in the 1930s. It reinforced significant racial segregation. It denied people from getting mortgage capital, and it continued to just permit these cycles of poverty. So back in 1984, very similar to Rick Donlan's story, when he said that him and his buddies made a pact, a blood pact, a similar thing happened amongst these four physicians in the 1980s. In 1984, they created our health center, and it's this really gorgeous, lovely story of, it started out with this high school teacher who we all affectionately refer to as Coach. He was a high school teacher that was talking with these students that he was leading a Bible study with, and they were praying about their community. It was a really impoverished area. After the Civil Rights Movement, after MLK was assassinated, there was a significant white flight that happened in North Lawndale. And after that time, the population decreased tremendously. I can't remember the statistics exactly, but decreased tremendously, and the area just became full of poverty. At that time, that coach, that pastor, they would meet on a regular basis with these high school students, and they would pray, and they would talk. This is coach right here. They would talk about what is the thing that our community needs. And what they said regularly was that we need a clinic, we need a basketball court, and we need a laundromat. And so they prayed about it regularly. The church all came together, and they were able to raise funds to buy this old Cadillac building. And what you'll see, this is one of the very first opening days in that building. This became actually, in the middle of our clinic, we still have a basketball court, which is something that we prayed for on a regular basis. You'll see kids running throughout the basketball court in our clinic spaces. This was the original 4 that came and did the blood pack that Rick talked about that helped start our clinic. This is a photo of what Londo Christian Health Center is now to this day. So these are some of the buildings that we get to house and work out of, and we basically have kind of taken over the campus of Londo, or taken over the campus on Ogden Avenue. We now have a fitness center, we have an immediate care, we have a pharmacy, we have an eye clinic. This is that Farragut High School that I was referring to before. Just to give you a little bit of a picture of what we're coming from and who we're representing. This is one of the clinic buildings. Over the years, they kept talking about, hey, we have a lot to offer here. God has given us so much. So that story of the talents that God talks about in the Bible, what can we do with that? And they had been rumors and murmurs about having potentially do a residency program. And 5 years ago, Ben, who's our program director, who's in the audience here with us, had the privilege of being able to help start a residency program. So this is 2 of our residents from our very first class a couple years ago, and glory to God, this is our residency program now. Yeah, come on, God is so kind, God is so sweet. So this is not only our residents, but their families, our faculty, their families. This is a retreat that we do once a year, and it is such a gift from the Lord. And something in our dreaming phases of this residency where God gave us this privilege of just being like, wow, you have been given so much with this clinic. Go and make generations of new physicians. We, when the program director and some of their leadership and I would talk about, okay, what is going to be significantly different about our residency program? If we've been given this opportunity that we have the privilege that at our workplaces, we get to have devotionals, we get to have worship, we are encouraged to pray with one another and pray with our patients, how can that change our training for our residents? So when we have our interview days, when we talk with our residents, we talk about, there's this line that the PD will always say, like, okay, Dr. Price, we hear all these different residency programs all the time. We go through all these interviews. What's so different about your program? And our answer every single time is this. It's our 2 main pillars. These are the pillars that we build everything off of. It's how do we live out our faith in medicine, and how do we live out the importance of health, community health and equity. So you all are here. It's Saturday. It's the last workshop. I'm impressed. Thank you all so much for coming. You are dedicated. So I'm curious. I want you to break out for 5 minutes and get into groups of 2s and 3s. How have you implemented faith in your practice thus far? How have you implemented the importance of health equity in your practice thus far? Because you clearly are here. You're interested. Maybe you haven't yet, but we're at a CCHF conference, so I'm pretty sure you have. But what has that looked like for you? Go ahead and share with your neighbors. Take 2 or 3 minutes, get in groups of 2 and 3, and just kind of talk through what have you done thus far before we get into what we're doing. Okay, I'm going to have you wrap up your conversations, kind of bring it back together. Come on back to us. If I could have somebody share from your group, what was one, maybe let's have 2 or 3 people that shared a little bit of, there was a lot of chatter going on. Well done. Way to be awake on this last day of the conference. I don't know about y'all, but I'm exhausted. But if we could have 2 or 3 people just share what was discussed, what was talked about. How have you seen it been practiced? How have you personally practiced? Yes, please go ahead. Amen. Thank you, Ms. Buckner. Appreciate it. So just to recap, something that Ms. Buckner had said that what she does is when she addresses patients, she finds the importance of calling them Mr. and Mrs. as she addresses them, and just giving them an equitable introduction and presentation to who they are, as well as finds time to offer to pray for patients. Anybody else? Thank you so much.
group of four. I can't wait to talk to him more afterwards.
Yeah, you want to just lead? Wow, praise God, that's wonderful. Just to recap, just for microphone recording purposes, Ms. Johnson was talking about how the fact that they would have a smattering of people that have been very faithful, that lead the crew at the free clinics, and then in their volunteers, not necessarily people of faith, but they're very clear in where they stand, and what is the driving force in their mission. But in the midst of their development, they've also developed prayer partners for that have exposure with the patients as well as among one another. That's great. Thank you so much. One thing I failed to mention before I hand off the mic, the role that I get to play in the residency program is I get to serve as the associate program director. I worked at Lawndale for about 10 years or so as a family medicine practice physician. My partner, who I'm going to hand it over to right now, who's going to tell you a little bit more specifically about what we do specifically in the residency program, is Jasmine Zagai, who's one of our faculty members, also family medicine.
Thank you, Liz. All right. So as Liz mentioned, I lead the community health and equity portion of our curriculum. We kind of think of this as similar to the other rotations as part of our curriculum, right? So we have someone leading OB, family medicine service, which is our inpatient service, pediatrics, and so on. And faith in medicine is led by Liz. I lead the community health and equity curriculum. So thank you all so much for sharing your ideas. We're going to spend some time now delving into what we call our methods for implementing faith in medicine and community health and equity. So first, we have our milestones. These were created to sort of reflect the ACGME milestones that you may or may not know of, depending on whether or not you're involved in a residency program. I'll actually spend some more time on the next slide discussing this. We'll also talk through how we meet with faculty who lead rotations, such as OB and pediatrics, to incorporate these ideas into the rotations. We'll talk about our quarterly grand rounds, which is dedicated time to specific topics within family medicine and community health and equity. And then we've also integrated these topics into didactics, precepting, and feedback in our humanities curriculum. So a lot of material to go through, and we're excited to share it. So yes, we'll start with milestones. But before sharing the milestones, I wanted to kind of give some context. So the ACGME is the Accreditation Council for Graduate Medical Education. It's a national organization that accredits residency programs, and it provides programs with 6 core competencies. These are used as a framework for tracking the progress of trainees and ensuring that they're ready to graduate. So these core competencies are highlighted in gray, the light gray specifically. And for each competency, there are levels 1 through 5, each of which are described using milestones. So that's kind of highlighted in blue here. And these define the skills and knowledge at different levels of training. So level 1 is kind of thought as this entry level, kind of where we expect interns to be by the end of their intern year. And then the goal is for them to kind of progress through the levels to the goal of level 4 by graduation. And then level 5 is kind of considered kind of expert level, aspirational. And that takes us to our own milestones. These are milestones we created. So these are the community health and equity milestones. And as Liz shared, our community health and equity and faith in medicine are pillars of our curriculum, right? So they're not just things that we talk about. They're part of, who we are and how we're living out our mission. But we kind of had to translate these concepts into curriculum. So the milestones are the framework that helps us do that. So starting with level 1, I want to share each of these with you. So level 1 is develops a broad knowledge base of healthcare disparities and their root causes, and recognizes the importance of addressing social determinants of health and overcoming barriers to equitable care. Level 2 is delivering patient care with a commitment to employing cultural humility, overcoming biases that perpetuate inequities, and utilizing a trauma-informed approach. Level 3 identifies and addresses community health assets and needs of Lawndale and surrounding neighborhoods. Level 4 is engages in efforts to improve community health and well-being through scholarly projects, advocacy, teaching, and community outreach. And then level 5 coaches and coordinates opportunities for others to participate in educational quality improvement, advocacy, and outreach efforts. So kind of generally moving from awareness and knowledge of health disparities to ensuring we're providing equitable care and then kind of broadening application of this knowledge to our care for the community.
I'm going to be honest, when I was doing the ones for faith and medicine, it was so challenging because there's so many different elements. Not to say that Jazz's wasn't, there's no shade. But we both talked about just the jargon and the way that we use these things. Because again, we use milestones in residency and generally to say like, hey, can that resident progress to the next step? Are they able to be graduated? And we really wanted to create milestones because we're teaching this curriculum, but to what goal, to what endpoint? And so as opposed to just kind of floating around of like, yeah, it's important to teach about community health and equity. It's important to teach like how do you incorporate your faith in your medicine. The reality is there are different levels of learning along these journeys, but it also felt really hard and a little bit punitive to try to think like, well, you're not really there with your faith in medicine, right? You're not really at level. Like there was a lot of nuance in how to judge or how to level how to grade or evaluate, if you will. And so we're still we've showed these to faculty. We've introduced them to our residents. We have yet to implement them into our evaluation. And to be honest, I don't think our goal or plan is to use them as an evaluation or summative, can you graduate or not? But it just gives us a framework of like, hey, what is our goal? If we really, like from day one, we've always said like our hope and our prayer is that our residents will not just graduate as really good docs, but they'll graduate as sons and daughters of the King who practice medicine, right? Like that's our hope and our desire. But it's hard to know. Everybody comes in the same way that everybody comes with different levels of where they started, depending on their medical training. Everybody comes with different levels of understanding of the importance of health equity. Everybody comes with different levels of understanding of just their own understanding of their own faith personally. And it's hard to really share that faith if you don't really know where you're at with yourself with the Lord, right? So there's a couple different aspects of a lot of the areas that I'll focus on is more so the resident's interaction with the patient, recognizing just level one of like the importance of spiritual health, right? There's secular studies out there that now show like, hey, yeah, this is really important. We need to address spiritual care for our patients. Whereas in the past, when I was in training, that was too taboo and it took too much authority over your role over your patient. And then we talk about one of our faculty members who's amazing, Casey Clardy. She talked about these stoplight cues, this idea of red light, yellow light, green light, of like, is the patient giving you any cues of like, this is not a topic I want to talk with you about right now? Or like, oh, wow, I really like your cross necklace. So like, oh, well, let me tell you about it, right? Like there's certain little cues that a patient can give you that's like, oh, I think that's a green light. Let's go for it. Let me tell you about Jesus. He's great, right? Like we'll talk about your blood pressure later. But so really they're like helping the resident learn how do we read these cues from our patients? Because we want to recognize that we do have authority when we put on that white coat. We never want to take advantage of that authority, but we also want to be, what's the word I'm looking for? We also want to be very explicit to like be clear why we're doing what we're doing. What's the why behind our mission, right? Excuse me. And then we talk about responding to patient-initiated explicit opportunities. If a patient asks you, like, hey, I would really love prayer, which a lot of our patients do. But there are many times when we also want the resident to be able to recognize, hey, this is not explicitly, but maybe they're talking about like, hey, just life is just too hard, or this chronic illness, I can't do this anymore. See that as an opportunity to explore a little bit more. And I'm not always necessarily just going to lay out the gospel right then and there, right? The beauty of being a family medicine doctor is that there's a continual relationship with your patients. But to help the resident to understand, hey, like that was a little bit of a cue. Did you notice that? That was something that was a little bit of a reach out, that there's something else deeper. There's something else going on that maybe he didn't explicitly say. And then level 5, which is on all the ACD milestones, is then how do you teach it to the next resident, right? How do you teach it to your medical student? How do you teach it to the next generation? Once you practice, that's the thing in medicine, right? Is you see one, do one, teach one. And so in the same ways, we really want to teach our residents to do that in these 2 pillars that we find so important.
Right. So yes, we'll be moving on to rotation meetings. So at our family medicine residency, each of our rotations is led by one of our awesome core faculty members. And so Liz and I will actually meet biannually with each of them, either in the form of meetings or kind of workshops, and we'll just brainstorm together. How do we incorporate this community health and equity and faith and medicine curriculum? And so these are very intentionally collaborative meetings. We invite the leaders to share their thoughts and ideas, but we also try to come with recommendations. And the milestones have been really helpful in kind of guiding our thought process of how we want to incorporate these things. So this is kind of an example of community health and equity recommendations that we provided for the OB rotation. So I could read through these, but in the interest of time, the level 1 is actually the example that we ended up incorporating. So currently we have a list of articles from this website, racecultureobgyn.org, and those articles highlight health disparities that affect our high-risk OB patients, and residents can choose from that list of articles and kind of provide a reflection or discuss it with the OB rotation leader, just as an example of how we've incorporated this.
I'm just going to highlight one way that we do faith in medicine, and this will be on our family medicine rotation service, where they're in the hospital caring for patients very long hours. One thing that we ask every intern to do is to take a spiritual history on every patient that comes in as an admission. Some of my residents are here in the room. They know, woo, 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 what's up? Thanks for representing. And they do a great job. It's part of as they're going through their HBI, as they're going through their SOAP note, this is part of the admission as they do a spiritual history too, right? The one that I'll highlight is on a level 3, also helping them to remember, like, these are not just the patient with pancreatitis. This isn't just the patient with alcohol use disorder. This is Henry, who also is a dad, who also has 3 kids, right? Who also worked on the railroad for a long time. And so spend time with your patients, because inevitably there's always downtime when you're on the medicine service. Not always, maybe not in the months of December and January, but there's usually some downtime. And so we also having something that we have implemented into the curriculum is to pick 2 patients and really spend time with those patients. And then at the end of your rotation, write a little journal reflection. Doesn't have to be long. Literally, it could be a paragraph. But just take time. So often the problem with training is that we see so much and we see so much brokenness, and we never actually take the time to reflect. And so it helps people to remember, like, oh yeah, that person is made in the image of God. I am made in the image of God. Let me take a minute to just remember that.
All right, so moving on to our grand rounds. So 4 times a year, our residents and faculty come together to learn and reflect on a specific topic within community health and equity and family medicine. These can be traditional grand round style versus more kind of interactive workshop style. Our most recent one actually was a field trip. So we went on a bus tour of North Lawndale and Little Village. That was led by a pretty well-known historian, Chicago historian named Dilla. And in addition to sharing about the general history of the community, he would highlight areas of historical injustice and community strengths as well. Another example is we had a grand rounds on correctional medicine that was actually led by the Deputy Chief of Medicine of the Illinois Department of Corrections, who outlined the disproportionate rates of incarceration of Black and brown men and how to practically care for people reentering into society. We had another workshop represented by the picture that starts with Matthew 5:1-10. And this was about supporting and advocating for our immigrant neighbors who were dealing with challenges resulting from our current social and political climate. In family faith and medicine, we had the missiology of medicine. So guest physicians would share how God led them to global missions and shaped their lives and the lives of their patients through those experiences. We had a bioethics seminar with speakers who helped us think about how our faith informs how we navigate really controversial topics within medicine. And these are just some examples. So, we found that residents really appreciate having dedicated time to explore topics more deeply and think about our identities as Christian physicians that are working in underserved communities. All right, so integration into didactics. Our didactics occur weekly, and they cover the breadth of family medicine topics. Generally, they're structured as a mystery case where we challenge residents to come up with a diagnosis using history, physical, and diagnostic testing. We usually follow that with a lecture-based or more interactive session on topical teaching, and then a workshop. This is just an example. This is typically very interactive, and here our residents were practicing back exercises for chronic back pain lecture. And our goal actually is to meet with faculty before each of their didactics. So prior to teaching, we help them incorporate at least one community health equity and faith and medicine topic. We'll usually start with a friendly reminder to include detailed social and spiritual histories in their mystery cases, and then we'll work together to come up with a way to integrate I want to say CHFM, and that's why I'm struggling to say it. So our nickname for community health equity and faith and medicine is CHFM. So I might just start saying it. It's so much of a mouthful. Yeah, okay. So CHFM. So here are some examples. So in an anemia lecture, we had a slide on spiritual anemia. So this is a metaphor for deficiency in hope. Residents and the teaching faculty had a really nice conversation about the ways they might be experiencing spiritual anemia, and how spiritual disciplines could help them stay grounded in their faith during residency. We also had a topic, community health and equity related topic for our HIV lecture that was on the intersection of social determinants of health affecting people living with HIV. We had a CKD lecture where we talked about the harms of race-based calculators and why the GFR equation was modified to avoid race. And then this last example came from one of our incoming residents, Andrew Kim, who is present here today. He inspired us to consider the parallels between the ovarian uterine cycle and liturgical calendar. Super interesting. So starting from the follicular proliferative phase, signifying kind of preparation for new life in Advent, and then ovulation, signifying the moment life becomes possible at Christ's birth, and so on. So we found that including these topics in our didactics has helped residents to really think about clinical care more holistically, even when having conversations about pathophysiology and medicine.
Okay. The next area, we're going to talk about precepting and feedback. What would be a residency without feedback? I just don't even know. So in precepting, so we basically do most of the precepting in our family resident residency clinic. So the residents will go and they'll see their patients. They come back and talk with us as the attendings, and then we'll come up with a plan together. Sometimes we'll go in there with them to go see the patient, or they'll just let them run free, spread their wings, and go see their patients on their own. And so one thing that we really, from the beginning, from day one, when we have faculty meetings, we really have encouraged our faculty, like, hey, this should really never be a place of shame. There is not a dumb question. Like, we know there's statistics about this, right? When people feel like they can't ask a question, or when they feel like there's fear mongering, or there's going to be pimping that's going to be happening, it's just hard to learn in that environment. It's what's been happened for generations and years and years and years. I don't feel like I'm that old, but it was also when I was in residency, and it's just frankly not helpful. I mean, I really knew some of that stuff well, but I don't know that I remember it still now. I just remember the feelings that I had with that surgery attending. And so and granted, we're also human and fallen, and we are not perfect at this as preceptors either, but our hope and our prayer is that this can be a space where residents can really ask questions and feel safe to do so. We also want you to have a plan. We don't want just to be spoon-fed, right? And so, yeah, you need to come correct, but also, like, let this be a place where Christ's love is shown. We recently had one of our residents who did an away rotation at one of our partnering hospitals in the ICU. And I just love this resident. She's a doll. And she came and she was like, oh, how was the ICU rotation? And she's like, oh, it's great. I learned so much. Those residents, they work really hard. And wow, Lawndale is like Candyland. Just compared to the level of just strife, or just not feeling heard, or just safety, right? And so it was just really affirming for the PD, and I was like, maybe we should be working harder. I don't know. Maybe we should like really toughen up. I'm not sure. But praise God, right? Like we really value that we feel really approachable to our residents. Because again, right, when we think about the example of Christ, that's what Christ was, right? So if we're teaching them about how to implement their faith, how to love people as Jesus, but we're not doing that as faculty to our residents, come on. It's not going to give the right message, right? It's not actually going to land. We talk a lot with our faculty about role modeling. So much of the teaching that we do as faculty is just through role modeling. My residents see how I interact with my MA. They see how I interact with the staff. They see when I walk in and I'm like, buenos dias, Acton West. Here we go. Let's start another day, right? Like they see that. And so it's super important for them to witness people that have been practicing for a long time. I've made a lot of mistakes. And so, yeah, learn from those mistakes and see how I'm working now. They didn't see how I had to go to apologize to the lab after a couple of years of working at Lawndale because I made some bad enemies just because I didn't say good morning. I learned from it now. I say good morning to everyone now, right? And so learn from the mistakes that I've made. And so we learn so much from the role models, and we have the privilege and honor to some of our faculty in our room here too, of working with amazing faculty who are excellent physicians and people that just love the Lord, and the love that God has inside of them just oozes out. And so it's easy to learn from people by just witnessing and watching. We also talk about goals. So one of our old faculty members who's sadly no longer with us, she's now in the mission field in Uganda, and Sejal Nuamanya came to us from Kahaba, and she brought goals. And so every time before she started a precepting shift, she had a tiny little sheet of paper that she'd print out that were what was your kingdom goal for that shift, what was your charting goal for that shift, and what was your time goal. And so again, just like having it at the forefront of your mind when you're about to go see your patients. This is a good kick in the pants for me too, because we kind of let go of this a little bit in the precepting spaces, and so we need to get more back on this as we're preparing for this lecture. And so then feedback. This is typically at the end of the clinic day. You've seen all of your patients. You've gone through. You've had some rough ones. There's maybe been some tears from patients or residents. Who knows? Depends how the day went. In the feedback, the residents know, like, okay, hey, is it time for feedback? Particularly for the intern class, where we really hit that more in the intern class as they get a little bit further along, as they grow and they see more patients, and they usually have to get back to the hospital spaces or chart. We kind of let them go off. But with our interns, we really, whatever faculty member worked with the resident that day, really want to take time to give feedback that day. And like anything, and before they come to residency, we mail them this book, and this is their reading that they need to do before they come to the residency program. We have a talk about it because receiving and giving feedback is super important. But it's really hard to receive feedback if you don't have a trust in that relationship, right? It's like any relationship. It's in a marriage, and it's a dating relationship, and a child with a parent. If you don't feel like the person's actually in your corner and wanting you to grow and wanting you to improve, it's hard to receive anything that they have to say to you, right? And so we work really hard as faculty, again, not perfect at it. I've made some mistakes for sure, but work really hard for them to know, like, hey, I'm telling you this because I want you to be the best doctor that you can be. I know that is your heart's desire. I know that is your goal. And I've made some mistakes. I've learned some things along the way. Let me help you in this process. And so really wanting to make sure that that relationship is based in trust, and so that they can receive the feedback. Because inevitably, right, part of the reason that residency is so hard is because you're just being told that you're like, well, you did okay, but you could also do it this way. You did okay, but you could also do it this way, right? Like just constantly like, you're inadequate, you're inadequate, you're inadequate. That's not actually what we're saying, but that's a lot of times what people are hearing every single day when they're in residency, on top of all the brokenness that they're already seeing with their patients. And so it's exhausting, right? And just absolutely exhausting to feel like you're not doing things well every day for a very stereotypical type A achiever group of people, right? Like that group of people wants to do things well. They're constantly working harder and harder and harder. And if you're telling them that they're not doing it, it can be exhausting. And so really being intentional to do it in love, to bathe it in acceptance and in trust is really important. One thing that we've started to implement this year, and again, trying to be more active about it, is having bi-directional feedback too. And so that kind of levels the playing ground a little bit with our residents and our faculty, and being more proactive. Some of our faculty are better at it than others. I'm still trying to get that rhythm of it, but having a space of like, hey, I'm still learning to be a teacher. What feedback do you have for me? How can I be more available to you? How can I teach you better? Did I just go off for too long and you had other patients waiting that you're like, oh, Redican, shut up already. I got more people waiting, right? Like help me to be a better teacher too, so that again, it's building that trust with your residents. And prayer. Many of my feedback sessions at the end of the clinic day have ended in a lot of tears and a lot of hugs and a lot of prayer, because it's just a vulnerable time. And it is, as a faculty member, is a privileged space to be in that space. I know I didn't say the classic words CCHF in these last two slides, but this is all full, right, of equity and of Christ's love for one another. And so much of it is just how we live out these roles day to day. The last piece that I'm going to talk about is our humanities curriculum. So Yeah, I didn't know that I loved humanities as much as I do, but I do. The benefits of humanity in medicine, there are so many things are really depletive. And for one time, we just really wanted to have what could be something that could be restorative to our residents. And so let me also say there are scholarly requirements that residents have to do. Humanities can be one of them. So we really wanted to make one of the scholarly projects, hey, can this actually be something that's not just another to-do list for our residents, not just another thing that they have to check off, another thing that they have to hand in when they're already exhausted, but can we do something that can actually be really restorative for them? And what we know is that humanities and medicine, they do enhance our communication and observation skills. They do foster a tolerance of ambiguity, paradox, and sensitivity in language. They have ingrained aspects of empathy and professionalism in there. And so we started a curriculum where we meet, I'll show you the schedule. It's probably every 1 to 2 months. And so instead of one of our traditional didactics that Jasmine has expressed, we'll just do humanities. So we'll still do our typical announcements and typical prayer. Oh, that's the other thing. We do prayer every Wednesday before didactics. But we'll do the rest of that session just on on humanities. We have a clinical psychologist that works at a nearby college that also works at Lawndale part-time with us that comes in and she's taught a lot of these lectures. She's done a lot of her own humanities. And we talk about, just as Wayne talked about yesterday, right? Like we don't remember statistics, but we remember the power of story. And the power of story is used so much in medicine, more than statistics often, to really advocate for our patients, to kind of drive home the punch, but it also is really healing for the physician who's lived through it too, or has had secondary trauma as they walked with their patients. And so again, just thinking about the power of story and the benefits of humanities. And also, again, thinking about our example. This is what Jesus did all the time, right? He talked in stories to the people that followed him, to his pupils, to the people that were learning from him. For the interest of time, I'm just going to keep going. But this is the curriculum that I affectionately call it the holistic healers. But so we had, this is a schedule that we use this year. And so for one session, we would just have them, we would do an hour teaching on, okay, how do you write a 55-word story? It's something that's done regularly, published in medical journals. And so we'll usually use a patient experience. And they'll remember a patient encounter that they've had, and they'll write it out as a story. And it has to be exactly 55 words, so it doesn't take very long. The nuance of the number of the words can be a little bit tricky, and sometimes that can take a little bit of time. And then we share them. We share them as a group. You don't have to. It was opened up, but it was really neat to see once one person shared and then the next person shared. And I was like, oh, I kind of want to share mine too. Whereas like when he first started, like, I'm definitely not sharing my story. But then once more people shared, I was like, oh, wow, yeah, I want to be a part of this as well. And before you know it, laughter is rolling, tears are flowing. Like it was just a really rich time to be, for both faculty and residents, to be unified in that and just share their experience as a physician. And there were some stories that were just really delightful and hilarious. There were some stories that were really hard and didn't really have a good ending, right? And you still have to hold that tension. But the beauty is that we were able to hold that together. We also had a narrative story where you can just, again, not necessarily a limit to the words, but just write freely about an experience. We have a Where I'm From poem, which is goes back from some a type of poetry. And so basically just talks about your origin story. And it has this rhythm of where I'm from, blah, 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 blah. I'm from the hills of Montana. I'm from the smells of street food in Louisiana, right? Like just these persistent mantras of I'm from. And it gave us a little bit of a taste of like, oh, these are the people that we get to work with, right? We get to work with really amazing people, but oftentimes we don't really have the time and space to delve into that a little bit more. And so it gave a little bit of insight into who each of us are. We had another session where we're going to have another session. We're able to finish our narrative essays, finish up our products. And then the last bit is at the end of the year, we have a symposium. So we've only done this one. We're a fairly new residency program, as I mentioned. We just had our first graduating class last year. And so we've just had the one symposium. And one of this was Dr. Benjamin Watt, who's one of our third years right now. One of his art projects that he wanted to do for part of his humanities is he wanted to write a comic. And so he drew out a comic of a little cat. I don't know if you can see the image, but it was going through the halls of the hospital that we work at Mount Sinai. And it was just incredibly quirky and endearing and lovely. And we all just, yeah, it warmed all of our hearts. And he read it to us like as if it was a little bit of a story. In this particular humanities curriculum that we did last year is a little different than we're doing this year. We also gave them the freedom to do other artwork. And so one of our graduates, Daniel Zoe, he decided to share some music that he had that had kind of like helped him through the training years. And so he practiced in our office spaces because he couldn't practice at home because of the apartment his neighbors wouldn't allow him to. Which they shouldn't have because he plays beautifully, and then just shared some music with us. It just was a really, really sweet time. And again, just getting to see different sides of us as opposed to just talking through. Okay, wrap up your conversations. I love all the talking. This is great, but me to stop. Bringing the conversations to a close. Thank you so much. You're doing great. Thank you all so much. Wow, I just am so impressed by the participation at the 11 o'clock workshop and the last day of the conference. Well done, team. Well done. Can I have a couple of volunteers to kind of just share some of the things that you guys talked about? There was a lot of chatter. There we go. Yeah.
So we're medical students, so we're still early on and benefit conversations we have and hopefully like work through the question.
Yeah, thank you so much. Just for the recording's sake, I'm just going to repeat briefly. I can't say Miss or whatever because I can't see your last name, but no, you're good. Ms. Walker had mentioned how the importance of just as a medical student taking home the thing that they're going to implement is just taking a spiritual history on their patients, taking the time and having it be a part of their regular practice. But Mason is also in the audience here who came and did a workshop with our residents who talked specifically about that and even just combated the lie that like, oh, it's just going to take too long. But the reality is if it's a part of the rhythm, it literally takes, 30 seconds. So just like, hey, are you a part of a faith community? How can we implement that in your practice today? Done, right? Like it doesn't take that long. It might take longer depending on the patient's answer, but that is also an opportunity to delve in a little bit deeper. Yeah.
Love is where I'm from. I just love the template.
Sure.
How long do you spend on that?
Yeah, great question. What we'll do is we usually similar format. We'll have about an hour or so of teaching about how to do it. We'll give examples of what that poem looks like, have people read those examples, and then we usually give people maybe 30 minutes or so to write. We have them come back together and people share a little bit of their drafts and do a little bit more writing time. And so in general, the sessions are about 3 hours long, an hour of teaching and equipping, and then 2 hours of kind of reflecting and writing and sharing. Yeah. But the hope at the end, right, is that at the end of the showcase, what our ask of each of the residents, we've given them protected time to work on these things. And even the last session, as you saw, was just like completion. So there wasn't actually a new thing that they're being taught. And the hope is that the requirement, hear me clearly, is that you are going to take home you're going to pick one of the things that you worked on, and then you're going to present it at the showcase. Because all the residents love the showcase, right? It was just this wonderful thing. But when we came to them, we're like, yeah, this is a requirement. They're like, what do you mean? I'm like, well, we have to have something to show. Like, that means you all have to bring something, right? And so having them pick one of those things, and faculty is available to help for edits too. Great. What are they? Anything else? Oh, wonderful. Go ahead.
Well, I came from a different, because I'm in education. So I learned some of the things you were doing. So I like the mystery case.
Yeah.
And so I was just writing notes down about what I could do.
Yeah.
But I was using your mystery case and using it to kind of like a flip class and have them do it outside of class, give them time out. But having it be on social determinants of health,
Yes.
health disparities with a mystery case.
Yeah.
And then coming back and putting it into that. And improve.
Yeah. Yeah, no, that's great. Thank you so much. Yeah, for the recording and just talking about the importance of using mystery case as an example of ways of teaching, and even having part of your mystery case being on social determinants of health. Thank you for your comment. I'm going to hand it over to Dr. Zagai to finish this up.
All right. So yeah, in the weeks leading up to this presentation, we requested feedback from our residents and faculty on how they've seen the impact of our curriculum. And I'd like to share some of that feedback with you, both because it's encouraging, but also because it really illustrates the importance of naming the work that we're doing and being intentional about living it out day to day. So one of our faculty members, for instance, shared that they have noticed that residents and faculty are more intentional about why and how we do our work. And it reminds us that our mission is actually to share the love of Jesus and allow our faith to shape our daily practice. And at the same time, we're seeking a more just healthcare system and equitable outcomes for our patients. I really appreciated this feedback. This is from a newer faculty member who shared that they were kind of feeling this weight of compassion fatigue. And I think this kind of highlights the benefit of our curriculum for kind of resident faculty wellness and spiritual health as well. But she mentioned that seeing the residents invest in this curriculum was refreshing for her. She says that they have a foundation rooted in compassion, and they see our patients as Christ sees our patients, people made in his image. She also says that we're kind of given the tools and the space to advocate for the sick and unhoused. A couple more pieces of feedback from faculty. One commented that our curriculum grounds a residency program in our kind of identity and as Christians in medicine, serving in an underserved community. The other mentioned that they've been pushed to kind of consider these aspects more as they teach bread and butter medicine. And then our residents also provided feedback. One shared how they've been learning more practical ways to reduce disparities in our community, and then also practical ways to bring God into the exam room. That same resident also mentioned that they appreciated the protected time for thinking about these concepts, and that we use evidence-based resources as well. This resident talked about mystery cases being opportunities to provide social and religious context to patient scenarios, which allows residents to reflect on the diverse identities and backgrounds of our patients and practice empathy. And then last is a quote from a resident who shared that our curriculum served as a reminder of God's love for her. So kind of tying all these comments together, I think they're threads of showing compassion, identity, and recognizing God's love for us and the patients we take care of. So in the interest of time, I think we are going to skip this question and just open it up for questions that you all might have for us. Yeah, racecultureobgyn.org. Yes, really helpful articles and podcasts as well.
I'm sorry, repeat that one more time.
racecultureobgyn.org.
I'm going to put up our email down here so everybody can actually. If you have any further questions, you are always.
Fine. I think it's great. I'm just trying to find a way to squeeze it in without taking away CCHF.
Yeah, you're specifically speaking to like the didactic portion, like in the teaching time? Yeah, it is. And so honestly, it's similar to, I'm going to treat you like one of my residents. So similar to taking a spiritual history, it doesn't take that much longer. So literally like the examples that Jazz gave about spiritual anemia was literally one slide. It was one slide in all the midst of the teaching. Maybe it took 4 minutes just for the residents to take a pause of just like, hey, I want you to just think about this idea that are there areas that you are deficient because you're not actually building your stores of iron in the practice of like with your spiritual life? Are there areas that you feel hopeless or deficient because you're not actually building up those stores, right? And similarly, maybe the GFR teaching, one slide. Hey, let's also recognize that when the creatinine clearance calculation that was created, that was race-based, there was no legitimacy in the studies that for the reasons of having it be race-based. So there's no reason that we need to keep using that. And this is another example how like health inequity has damned is not the word I'm looking for, but has really just been disadvantaged for our Black population or Black, right? And so it doesn't necessarily have to take a long time. Now, there's been other examples. Eric did a teaching, one of our faculty members, was it the prevent, can't remember what the topic was at the moment now. Yeah, for the prevent, for cardiovascular health, and how instead of using the Framingham risk, now changing over to the prevent calculation, when they had a little bit more of a robust discussion, right, about like why we did this and why it hasn't been done in the past. And I know one of our other BH faculty has had a little bit more of a robust discussion, particularly with the topic of bipolar and how oftentimes it's overdiagnosed in the Black population in the urban settings, particularly. And so let's talk about that, right? So it's really dependent a little bit on the topic, but what our hope and our prayer is that at every didactic, there's just like a touch point, right? Sometimes it's 15 minutes, sometimes it's 2. But there's a touch point of just like, hey, this is a priority, this is a pillar, this is something that's valuable. And so we're still able to get in the topics that we want of like so many for cardiovascular, so many for pulmonary, because they're just little touch points in our teaching. Does that make sense? Yeah.
I love how these analogies seem to go in really seamlessly.
Mm-hmm.
Can you give an example or a story of how it gets applied into patient care? Like how maybe a resident took what they learned and had an encounter with the patient?
Oh, do one of my residents want to answer that? Yeah, come on up, Blair. Yeah, come on up, sis. You got this. We're both wearing Carterized. You're ready.
I would say something cool is after, I think it was actually Dr. Song talked about Prevent Score and how you can use the zip code to learn about their CVD risk. And so I made that a dot phrase in Epic afterwards and used that with the ASCVD score just to compare. It's been super helpful. Another example is after talking about like maternal health in Black communities, just asking patients when I go to like my OB-GYN rotation. Yeah, when I went into like a room with a Black mother or a pregnant Black woman, and they're on the labor floor, just saying like, hey, statistically, Black females tend to have their pain overlooked and not heard. So our goal and our mission while you're here is that you feel heard. And if you don't feel that way from anybody on the team, please let us know. Please feel free to let us know, and we'll try and look out for it as well.
How was that received?
I think patients really appreciated that comment. As far as like, sometimes, it's about exposure to that knowledge among staff. So also just educating like medical students and other staff when you can to advocate for your patient. Yeah.
That feel in my head one, but I've actually had the honor of being one of her
Oh,
patients.
Man. Come on, Dr.
Right, so her, it was just so professional and down to earth at the same time. I really felt it was amazing.
Yeah, I'm one of the interns this year. And so one of the ways that I've really appreciated our didactic space is they really do try to provide practical ways to incorporate it. And so part of it is giving, particularly I think Dr. Clardy, I think is really good. She's one of our behavioral health psychologists who says like, mental health is a gray area for a lot of patients, and she gives us real example ways of how to approach these topics in a way that's very sensitive, but also glorifying God and being, and having nuance and making sure that we're not harming, but we are actually providing like something that's helpful and something that can allow patients to grow in a way that oftentimes feel hurt by the church. And so I think it, it's even our dot phrases in Epic too of like getting a spiritual history. It's like getting reps and getting comfortable with just like asking the question. Like, is this something that's important to you? And it helps me check myself at the door of like making assumptions or thinking that I don't have time or that they don't care or because I don't look like them that I'm not that's a way that I'm not, able to like get deeper with patients. And it's like, that's not true. And we have, a culture on our like FMS service that's like, our patients look forward to us praying those who want prayer, like really look forward to say like, I will be, there are patients who will come to us knowing that that's part of something like part of our care. And so what I appreciate is the practical ways of being able to incorporate that's obtainable and not intimidating in a way that's like, I don't even feel comfortable sometimes, like in the beginning, prescribing a medication that I know will work and how to approach that. So that's something that I'm really grateful for.
Amen. Kudos to our residents. Well done. And I think, just another simple example, right? Like there's been a time when I was with a resident in the clinic space and it was just really chaotic. There was 2 kids running around. The mom was talking about how like she didn't have money and it like the room just physically felt so heavy. And I could just see my resident just kind of shut down. And I was like, okay, well, let's pray. And so, we, at the end of that, we did just, it was again role modeling, right? So in those clinical spaces, role modeling like, hey, this is something that you can still offer. And role modeling the script, like Dr. Holly talked about, we give scripts or like how this is how you would say it. And then to see that resident saying like, then the next time I was just able to do it on my own, right? Or the next time that a different resident saying like, hey, my kingdom goals this time is I'm going to pray with 2 patients this clinic shift. So it's small little things, but those are ways that we've seen that play out. Sorry, we're over time. Here's the QR code. We would love, thank you all so much for your attention and for, just your attentiveness and your questions. It was really lovely working with y'all.